So as time has gone on, we've gotten better at determining, do you actually need to have this treated? Because if it's not going to shorten your life.
Because if you're 80 years old,
exactly,
90 years old, something's going to take you out. Your heart, a stroke, or something else. And if you have a little bit of prostate cancer, it's hanging out.
Most people die with prostate cancer.
They die with it. Hi, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Phillip Fish. Welcome to the show, Phil.
Yeah, thank you for having me.
Phil is a friend of mine, a good colleague, and Phil is a urologist.
That's right.
So tell me, Phil, what is a urologist in the world of medicine?
Yeah, well, I think it's a specialty that a lot of people don't know much about, but we're basically the surgeons, the doctors of the kidneys on out, the urinary tract. So men, women, kidneys, bladders, prostates, scrotum, testicles, penis, all of it.
All penis, the whole deal, the whole
right.
genitourinary system. And it's not just guys, even though guys, and we're going to be talking about prostate today, which is a guy problem. But the urinary system can get problems in both sexes. A stone is probably an equal opportunity offender.
Exactly.
And urology goes way, way back in the history of medicine, doesn't it?
It does. It does. It was initially a branch of general surgery, as most of the surgical specialties were. One of the first urologists was a guy named Hugh Hampton Young, who was from the East Coast. He was basically told one day by his chairman that he was going to be the head of the genitourinary surgery department. And he said, "I'm not a GU surgeon." And they said, "That's okay. You'll do fine."
You'll do fine.
And that's when it kind of split off from general surgery.
Here in the United States,
in the United States,
but it goes way, way back. The expression "cutting for stone" was a real thing.
Exactly.
And it was rather barbaric. If you look at the equipment they used and the people that died and the stone cutters in Europe that would operate in one city, and then while their patients were dying afterwards, they'd run to another city and just stay one step ahead of the disasters. And it was brutal, and I don't want to get into it, but urology is one of the oldest branches of medicine because painful kidney stones go all the way back.
They've been around forever.
They've been around forever, yeah. Now, the average life, I think in 1900, the average life expectancy was 43 for a person in the United States, and now it's almost double that.
Right.
So we have more time for urinary issues to come up, and that leads to the topic of today's discussion, that is the prostate. I will introduce it as the prostate is a gland that sits under the bladder in men. Mm-hmm. And in fact, this is an interesting embryology thing. We all start out as a fetus that could go girl or boy.
Right.
That's why guys have little boobs, because if we'd been a girl, they would have developed into boobs, right? And our things can go different directions. So these primordial tissues, if it's a girl, if the hormones and genetics are in a girl environment, this tissue will grow into a uterus. If it's a boy environment I won't go into all the hormones and genetics, develops into a prostate. So in the middle of the prostate is this little tiny nub called a utricle.
Yes.
That would have been a uterus.
Yep.
So it's an interesting blend of structures that develops into a prostate. The prostate's where everything comes together in a guy. The urinary system has to go through it. So urine from your kidneys to your bladder has to pass through the prostate to leave the body. The reproductive system, what are called the vas deferens, or the ejaculatory ducts, come into the urethra there too. So now we've got the reproductive part all merging in this prostate.
Exactly.
And then it leaves the body through the urethra. It's got other contributions. The plumbing of the male reproductive system is just amazing. But because it's in the crossroads, if you have any problem with the prostate, develops hard, it creates huge life-altering problems, doesn't it?
It does. Yep.
And the prostate has a lot of glandular tissue, and it turns out the glandular tissues of our body have a tendency or propensity to grow cancer. So prostate cancer is an enormous topic, and I hope to explore all these things with you, Phil.
Yeah, definitely.
So urology is primarily a surgical specialty. So after medical school, you have to undergo quite a lengthy training.
Yeah, it's about, so there are some 6-year programs still. I think those are becoming less and less common. But most of them nowadays, it's a 5-year training program.
So even after medical school, you have 5 more years.
5 more years. Plus, if you do a fellowship, another 1 to 2 years after that. So
of a subspecialty in urology. What type of subspecialties are there in urology?
You can do, male infertility, focus on the fertility issues that happen in men. You can do oncology and focus on, genitourinary cancers like bladder cancer, prostate cancer, kidney cancer. You can do endourology and focus on complex kidney stones. You can do a pediatric urology fellowship and treat children in the congenital urologic abnormalities.
Yeah, because sometimes people are born with abnormalities.
Exactly.
Both boys and girls can have abnormalities at birth.
Yes.
Wow. So just like OBGYN, there are numerous subspecialties. And, I did additional years of training in reproductive endocrinology and infertility. In the GYN world, they also have a cancer specialty, and they now have a minimally invasive surgery, a urogyn, which kind of overlaps with your world. So you can't even sub-specialize. So in order to become a urologist, you need years and years of training, and you have done that. And now you're in the trenches, and Phil, I hear wonderful things about you, by the way.
Well, that's good to hear.
I hear you both are a great surgeon and you have a wonderful, caring personality. So that's a wonderful combination. I want to welcome you to the community. You've been here about a year now?
Just about a year, exactly.
Just about a year.
Yep.
Well, I'm so glad you're here, and it's wonderful to have good colleagues to work with so we can treat our patients best. So we're going to talk about a very special organ in the male reproductive system called the prostate. And just some general numbers that I Googled recently is that if a guy lives long enough, he has about a 1 in 8 chance of developing prostate cancer. Recognized prostate cancer. You can have a subtle, slow-growing, what's called incidentaloma, just happens to be there. You live with it, you die with it, you never know you had it. Exactly. So the numbers are probably higher. But in the United States, there's at least 280,000, give or take, new cases of prostate cancer every year. 35,000 guys will die of prostate cancer, and that's just in the United States. And obviously, it's a worldwide issue. And I mentioned longevity and lifespan. That's important for this discussion because by the time a guy reaches age 50, about half the time, the prostate has just started to enlarge.
Exactly.
It has different names. The old-fashioned term, and tell me if it's much different now, is benign prostatic hypertrophy, or BPH.
BPH, exactly.
You still call it BPH?
Yep. BPH.
Very, very common. And if you live long enough, if a guy gets to around age 85, 95% of the time, the guy's got this BPH. And you don't realize you might not realize how big of a problem it is until it affects urination. And you have to urinate or mix. The medical term is micturate. Urinate
that's right.
is the production of urine by the kidneys.
Right.
The passage of urine is called micturate. So I know the difference, but I'm going to call it urination because that's what everybody calls it. And when you have to urinate more and more frequently, and then there's the middle of the night, it's a big deal.
Can impact your quality of life quite a bit.
Quality of life, yeah. And I, being an older guy, maybe this is too much information. I got to get up more often. And if the TV's on, half the time I was watching TV, that's when the ads for medicines and treatments are up because they know at 3 a.m.
You're up.
The person watching this thing is most likely a guy getting up to pee. Yeah, so I'll tell you a recent experience.
Okay.
I like rock and roll. I used to go to concerts when I was younger. I still go to concerts, not as frequently as I used to. And one of the greatest rock and roll bands of all time was Led Zeppelin. You can argue whether they're the best, but everybody, if you don't like Led Zeppelin, you can just leave now. Anyway, I went to a Led Zeppelin tribute band, a wonderful tribute band called Get the Lead Out. I love them so much. I'll give them a prop here. And the audience is older. Now, there are some young kids who appreciate it, but the audience must have been 60, 70 years old, right? So I, like a good 60-some-odd-year-old guy, went to the bathroom, right? And usually you go to a sporting event or a rock concert. This is for women who may not have done this before. You go and then there's a line of guys run. They go pee, run back to the concert. Go pee, run. It's this turnaround, right? So I went into the bathroom at this concert, and there's this line of guys standing there, and they're all 60, 70 years old. They're my age, right? And I'm waiting, and I'm waiting, and I'm waiting. And not one guy has moved. It seemed like forever. It was like a century. One guy finally finishes peeing. So it's this whole line. So if you want a statistical representation of how common is BPH, and it takes a long time to pee, and it's just everywhere. It's a big problem. So talk about an issue that needs a urologist. There you go. So let's talk about this common condition, BPH, benign prostatic hypertrophy. Why does it happen, Phil?
So the prostate has an enzyme that's called. This is going to get a little bit into the weeds, a little bit technical.
Please do, because I hear all these different explanations. I'd love to hear it from you.
So there's an enzyme called 5-alpha reductase, and it is an enzyme that converts testosterone to another form of testosterone called dihydrotestosterone.
A powerful derivative.
Powerful derivative, and that drives the prostate cells to grow, the endocrine cells of the prostate to grow. It's actually what also causes male pattern baldness. So medications like Rogaine is basically a topical medication that it prevents that conversion.
Very interesting.
So one of the medications that we can oftentimes go to in men with BPH is it's called finasteride, or dutasteride is another version of it, and it basically blocks that conversion. It's almost like an oral version of Rogaine. It can help shrink the prostate down.
I hear everywhere, and from different sources, that it's DHT, this dihydrotestosterone, or it's testosterone, or it's cortisol, or it's estrogen, or it's inflammatory this, or we don't know what causes it. I mean, it depends on who's selling what.
Exactly, yep.
Right? But in your opinion, the best evidence suggests it's DHT that causes this enlargement.
Yep.
So, it seems like an easy fix, Phil. It just takes a DHT, a 5-alpha reductase inhibitor, problem solved.
Yeah, you'd think so. And actually, finasteride, I tell patients all the time, overall, it's not the best medication for BPH and the urinary symptoms that come from it. A lot of times when guys come in for treatment, it's been such a long chronic process that they haven't necessarily noticed how bad it's gotten. And you get some changes in the bladder that can cause some overactivity, some leakage of urine. So the finasteride can slowly shrink the prostate, but most people don't really perceive a huge benefit to urinary symptoms.
So
overall.
Once it's grown, you can't go back.
Correct. It can shrink a little bit, but most people it's just to try to stop the growth. So it's probably the least common medication that we use.
Really? You think it'd be the most common if that's the problem? So you can't fix it. You can't cure it with medicine.
You can usually kind of put a patch on it and hope that things just don't get worse.
Wow. So let's say a guy's got this. He's got to go. You can't. You can't tell. It's so frustrating for a guy. He's got to go, but he can't go.
Right.
So he stands there.
Yep.
So that's the typical thing. Like the ads on TV say, "Hey, you're getting up all the time, and you have a poor flow, and blah blah blah." I'm sure you hear this all day, every day. I bet you it's half of your office visits. What other things can you do, Phil, for BPH?
Usually the medications we go to first are a class of medications called alpha blockers. They basically block some receptors in the prostate and the bladder neck to try to relax it, improve flow, improve emptying. Those are if you've heard of Flomax out there, tamsulosin, alfuzosin, there's a whole number of medications in that class, but that's usually going to give patients the biggest immediate benefit to their symptoms. And a lot of people that we put on these medications will come back and they'll say, I didn't even know how bad it was until I started that medicine, or my prescription ran out. And I really noticed how bad it was when I didn't have the medication anymore. So that's usually where we start.
So you start with what are called alpha adrenergic blockers. Now on the flip side, there are medicines out there that are alpha adrenergic agonists.
Yes.
That are used for cold symptoms and all that kind of stuff. So what can happen to a guy if he happens to take some like some Sudafed or something like that?
Yep, you can go into urinary retention. Basically, you're kind of right on the edge there, where your symptoms are maybe worse than you think.
Yeah,
you take one of those medications, and it can stimulate those receptors and go into retention. Stop, not be able to urinate.
Now you can't pee. So now you're full and you can't pee. That's a terrifying place to be.
It is,
and you can get guys in the emergency room with that. Oh my God!
Some of the most uncomfortable patients that I've ever seen are the ones that go into that acute urinary retention, and they've got liters of urine in the bladder.
Liters.
Yep.
Oh my God! Now normally a bladder's going to hold a half a liter, or maybe a woman who's
a nurse maybe who
has to hold her pee all the time might
Yep.
hold a liter or so.
Yep.
Apparently, in the old days, I hear this is probably true, that out in the Wild West, when there were no bathrooms, it's the 1800s, a woman's got her dress, and she said, they had to hold their urine all day. There was no place to go, and they would have enormous bladder capacities.
Yep. I think the most I've ever personally drained from a bladder is 2.8 liters.
2.8 liters.
And that was a guy who had such chronic urinary issues that he felt like he was emptying. So he told me,
he
said,
was
I know
emptying.
I'm urinating, I'm emptying. He was not.
And 3/4 of a gallon.
Yep.
Wow. So if a guy does have this urinary retention, takes some Sudafed, all of a sudden can't pee, what can you do for him, Phil?
Usually first step is to just put a catheter and get the bladder drained.
Put a tube in there and drain it.
Exactly.
The
It's just
tube
plumbing
opens
at that
it
point.
up. Just plumbing.
Yep.
Problem
Put a tube in
temporarily
there.
solved.
Yep. Give it a little time. If they're not on medications, we'll usually start them on medications like an alpha blocker to help them, be able to avoid when we do take the catheter out. And just give it time, usually 5-7 days, and let it resolve, let everything kind of calm down.
Now, do these alpha blockers have some side effects?
They do. So they're not, most people tolerate them pretty well, but alpha receptors are all over your body. The ones that we use in the urinary tract are pretty specific for those receptors in the prostate, but they're not completely specific. So alpha receptors are also what in your vascular system,
in your blood vessels,
they kind of keep your blood pressure up. That's one of your fight or flight responses. Those alpha receptors get activated, your blood pressure goes up, your vessels constrict. So in some people, they can get a little bit of orthostatic hypotension where you stand up, your body doesn't compensate well because those receptors are blocked, and you can get lightheaded or dizzy.
Or even pass out if you're super sensitive. So
Exactly.
it's not without side effects, these medicines. What other prescription medicines are out there for BPH, Phil, that people should know about?
The third one I think that sometimes we forget is PDE5 inhibitors, Viagra, Cialis, the medications that we give for erectile dysfunction. One of them, Cialis or tadalafil, if you have both benign prostate hyperplasia and urinary symptoms and erectile dysfunction, you can do low dose daily Cialis, and it can help with both issues.
One stone, two birds.
Two birds, exactly.
Interesting. Now I see ads, and YouTube and Facebook know I'm over 60 years old, and they feed me. They know I'm the targeted demographic. And I do that on my ads too. I mean, I'm looking for women aged 25 to 40. Everybody does it.
Yep.
And I get targeted with these supplements or these herbal medications.
Yep.
And
saw palmetto,
that you know exactly where we're going. And I remember seeing this little infomercial thing, and I happened to watch it. I was curious, and it talks about their supplement. It says how horrible saw palmetto is, or it doesn't work. And then it sent me to this thing for their supplement. And I looked at it. You know what it was? It was saw palmetto. Bastards. So what's going on with saw palmetto? What's the active ingredient in saw palmetto?
It is basically a supplement. To be honest, I don't even know what the active ingredient is. I think
it's called beta cytosterol.
So super beta prostate. That's where that name comes from.
That's where they get the name.
So I have a fair number of patients who come in and they'll say, I'm on my, I'm taking saw palmetto.
Already started taking it.
They've been taking it because they've had some urinary issues. I generally tell them that I don't think it causes a whole lot of harm.
Okay.
But there's no good data that it's going to really improve the symptoms. So I'll never tell them you have to stop this medication. If they come in and they're happy, we can add some stuff if they're having some issues that's just not taken care of. But I don't really prescribe it or tell people to take it.
Yeah, I read a review article on it last night, and it said they look at the level. Does it inhibit at 5-alpha reductase? Yeah, it does. But clinically, they say maybe there's a small benefit.
Yeah.
You see why it's not a prescription medicine. If it were effective, somebody would have purified it and made it into a pill and made a lot of money on it, right? So when something is herbal or whatnot, the money you're going to make is your profit margin and your marketing.
Yep, it's like essential oils, right? They're probably not going to hurt.
Right?
Will they help? I don't think so.
Right.
But if you want to use them,
So no great data that saw palmetto is going to fix the problem.
Correct.
Might be marginal.
Yep.
So a guy's tried the medicines, he's tried the saw palmetto, and the symptoms just keep getting worse. How do you know it's not a cancer, Phil?
It's a good question. So, there's an enzyme that the prostate makes called PSA.
PSA, prostatic specific antigen.
Antigen, exactly.
Tell me about this test. There's been a lot of controversy recently about PSA.
There has been. So it's a normal protein made by the prostate. Some of it gets into the bloodstream. We can take some blood and measure how much PSA is in there. We use that as a screening test for prostate cancer because most prostate cancers make or oversecrete PSA. So an elevated PSA can be a sign of an underlying cancer. There's a lot of other things I tell patients all the time that can cause the PSA to go up, like an enlarged prostate, right? You have more prostate tissue, your PSA goes up. But certainly we expect it to go up to some degree in prostate cancer. So we use that as kind of a marker for that.
Okay, so we have what's called tumor markers. And there are other cancers very specific. You got this chemical in your blood, you've got it. And we talked with Dr. Iliff about this new Gallery, I think it's called, test that very specifically can tell you if you have cancer in your body and what type it is.
Yep.
But some markers are non-specific, and we have that in the GYN world too. There's something called CA125. It's secreted by ovarian cancer, but a host of other benign conditions also secrete it. So there's no number. It's a you have it or you're not. There's a world of gray.
Exactly.
So I don't know, for 10, 20, 30 years, maybe, I don't know exactly, PSA has been part of the screening test for guys. You go in for your annual, they check your blood sugar.
Exactly.
They check your cholesterol, which is bullshit. And I'm going to have other guests on for that. All right. I said it. And then they'll throw a PSA in there, as a screening test for guys.
Yes.
And I think that was standard care for a long time.
It was. Till recently.
So what has happened?
I think so. There's a thing called the U.S. Preventative Services Task Force, or the USPSTF, and they come out with screening guideline recommendations for primary care. And they had done a bunch of studies on PSA screening and prostate cancer survival, and their conclusion was that screening for PSA didn't really impact survival. And they said we shouldn't necessarily give it to everybody.
Right. So this is very important. Mm-hmm. When you do a study or an analysis or whatever, you're answering the question you're asking, right? Hopefully, if it's done well and if everything works out, you're answering a specific question. But the question is that question the right question?
Exactly.
Right?
And they're using data from decades ago, right? This is all data in the past. And the treatment, the management of prostate cancer has changed significantly over the last 10, 15 years.
Yeah.
So they're basing this on data from decades ago when the treatment has really changed.
And they're also looking at a population, and they're looking at cost-benefit analysis.
Exactly.
And in countries where you have national health care, they only have so many dollars or yen or pounds or Canadian dollars to throw at a problem. These people, the bean counters, the masters of public health, who we need, who are very valuable, are not looking at the individual person. They're looking at dollars spent and return on investment and lives saved. Right. All right. So in this analysis, if I make sure I understand it correctly, they're looking at the overall population and lives saved or years gained or what have you based on this test. They're not saying, do I as an individual benefit from that test in my lifetime?
Exactly.
Right? Am I saying that correctly?
That's exactly correct.
So the study comes out and says, hey, maybe it's not cost effective. We're not getting very much bang for our buck. But what are your feelings about? But the PSA test hasn't changed. It's still
prostate cancer overall hasn't changed a whole lot. I think
that
I mean, obviously I'm a urologist, so I'm a little bit biased, but I think in the last several years we've definitely seen more advanced prostate cancer, widely metastatic disease that comes in.
Right. The trade-off for not doing it at your annual exam with your family doctor is that you're going to miss some.
Correct.
And by the time you notice you have it, you're peeing blood, it has spread and it's more advanced now.
Exactly.
So that's the downside of not getting a PSA.
Yep. And I think that's definitely become more common in the past several years.
Yeah, people are seeing that. You're not the only
people
one.
Come in with, normally PSA of 4 is kind of our normal, abnormal cutoff there. We'll see people come in that have never had a check. They have some urinary symptoms. They get a PSA and it's 200, 300, 500.
Hundreds.
I've seen greater than 5,000.
Oh my God.
Mm-hmm.
Oh my God. So if a guy goes to his family practice doctor for his annual physical, annual checkup, getting a PSA is okay. Am I hearing that correctly?
It is, yeah. We generally recommend screening between the ages of 50 and 75. Men that have a family history of prostate cancer, so first-degree male relative, dad, brother, that's one of the biggest risk factors for prostate cancer. So if it was diagnosed at a very young age, we would consider screening a little bit earlier. But the general population, 50 to 75, is when we start checking.
Well, that makes sense. It's the same thing with women and breast cancer. If your mom had it early, your grandma had it early, start testing early. Mm-hmm. So there's nothing wrong with getting a PSA. And the recent changes, I'm summarizing here, and the recent changes and recommendations are based more on population-based cost-benefit analysis than the benefit maybe to you as an individual.
Correct.
Okay. Because I get a PSA with my annuals, and it's very reassuring when it's low.
Exactly.
Nice and low. Mm-hmm. Now, I've heard that an examination, now this is the worst part about prostate, is the prostate is deep in the pelvis, and it happens to be right in front of the anterior wall of the rectum. Conveniently. But that's what guys dread the most. But the prostate can be palpated or felt, what's called a digital rectal examination. The urologist feels the prostate through the anterior rectum. Mm-hmm. And in doing so, and it's amazing. Now, when I'm doing a pelvic exam in the GYN world, I can tell you how big the uterus is, where it's located, how many weak sides, there's a little nodule here, blah, blah, blah. You guys do the same, and there can be gals. You folks can do the same thing with the prostate, can't you?
You can, yeah. You can get a rough estimate of size. And then some people, the way that the prostate, develops, there's a zone in the back called the peripheral zone, and that's where the majority of prostate cancers happen. So it sits right there on the rectum. So some people, you can feel a specific area that's concerning, that looks like there's a high suspicion for cancer. So that's why, PSA and rectal exam, digital rectal exam is kind of the go-to screening test for prostate cancer. I'm not going to lie, I don't do a ton of rectal exams on patients. Usually when they see us, the PSA is elevated, so we're going to do a biopsy regardless. We're going to, if it's a urinary issue, BPH type issue, we're going to get some imaging to kind of measure the size of the prostate. So,
gotcha. So what I wanted to go over is that should you get the PSA blood level drawn before the exam or after the exam? I heard that doing the exam can raise the levels, but that might not be true. What do you understand?
It would have to be a pretty vigorous exam.
Okay, so you'd really have to squash that prostate to squeeze that PSA into the blood. Mm-hmm. So it's not I just had my exam, let's put off getting the blood test. So just get the blood test. Doesn't make that much difference. Mm-hmm. So, Phil, let's say a guy's having these urinary systems, you examine him, his prostate is enlarged, his PSA is normal, so you're not suspecting very highly prostate cancer. What can you do about BPH once it gets really bad and medicine's not working and the guy's quality of life is just miserable? What can you do about run-of-the-mill BPH?
Yeah, so there's a bunch of different surgeries we can go to. That's basically the next step. If the medications aren't working, usually it's to talk about surgery to debulk the prostate, to remove some of that tissue. I tell people it's like, squeezing a garden hose,
Right.
It impacts the flow, so we need to open it up and take some of the prostate out. And there's a bunch of different ways you can do that. A lot of it depends on size of the prostate. There's certain therapies that are really good for smaller prostates that have bad urinary issues, and then there's some that are better for really large prostates that are causing urinary issues. And then it comes down to, everything has a side effect. Every surgery has side effects. So kind of knowing what the patient's goals are, what their concerns are. If they're really concerned about sexual function, that's something that we have to take into account as well. But usually surgery is the next step in that situation.
So tell me about these various options, please.
Yeah. So we measure prostates in size in grams, and 20 to 30 is kind of considered normal. So
about a walnut size?
About a walnut, exactly.
Okay.
I've seen them get up to 500 grams, so very, very massively.
So you can get it almost a grapefruit.
Exactly.
It's really an orange.
The ones kind of a lot of the treatment options are for people in that 30 to 80 gram range, and that's where most of the patients that we see are as far as prostate size. There's some less invasive procedures you can do in clinic that have less sexual impact. In general, I tell people the more invasive you are, the more tissue we remove. tends to come with some side effects. There's a trade-off there, but long-term has better outcomes as far as urinary symptoms. So there's a thing called urolift where we go in and basically it's kind of like stapling open the prostate, kind of hold the sides apart so the channel's opened.
I've seen ads for that on TV. It was a fire boat squirting, spewing water into the harbor.
Exactly.
Yeah.
So that's a good one for I'd say younger men tend to like that one because there's really not any sexual side effects associated with it. No ejaculatory dysfunction. So that's good for the smaller glands that have concern for those kind of things, but we don't take any tissue out. So eventually the symptoms tend to come back.
So it's more what's called temporizing or a temporary. But it also leaves a foreign body. You've got is a plastic staple
it's
thing?
Basically like a permanent stitch, and there's two basically they're like anchors.
It's
on either
what
side.
Holds the label on your clothing, right?
It's exactly right.
Exactly. But now you got a foreign body in there. Can get irritated or infected or
not necessarily infected. I have seen people get some stones that form on them, some calcifications. They can act as a source for stones to form, especially if their urinary symptoms worsen and they're not emptying well. They can act as a source of stone formation.
And you can do the urolift in the office, did you say?
You can do it in the office or you can do it asleep. There's another one that we do in the office called Resume, and it's basically where we inject heated water vapor into the sides of the prostate.
Essentially steam, right?
Steam, exactly.
So you could do a steam treatment.
And that kind of causes it to slowly die off. So that one does remove a little bit of tissue, so it's a little bit more invasive, maybe a little bit more durability there, but something that can be done in office as well.
Really, and you can't do it when they're asleep too.
Correct.
I'm such a weenie.
Yeah.
I'm such a weenie. I would want to be asleep for that one. But so you can steam treat. And how effective is that?
It's pretty effective. I mean, I think kind of, like I said, the more you take out, the more improvement you're going to get. So we're not taking out the tissue. It's kind of slowly dying off. Some people get some overactive bladder, some irritation with urination for a couple months after the procedure as everything heals. But there's some pretty good data that it improves flow quite a bit. It's a newer procedure, so it hasn't been around for decades like a TERP, which we'll probably talk about soon, I'm guessing.
Yeah, we're getting to that.
Yep. So
the gold standard or the old fashioned.
Exactly. So I think there's a good improvement there in symptoms. It can be used in people who maybe they're having bad urinary issues, but they're not the healthiest people and they're not ready
Poor
to
candidates.
Go to sleep. Exactly. You can do it with them with just some kind of conscious sedation in the clinic.
Now, does Resume block the vas deferens? Does that make a guy sterile, or they still stay open?
Most people are going to still be open there,
Okay.
and still there's not as much ejaculatory dysfunction, as there would be again with TERP.
All right, so we've got the staple, the steam treatment. Are there any other treatments short of the TERP, which we're going to get to in a second?
There are. So there is one called iTind, ITIND. It is basically like I tell people, think of it like a cage that we put in the prostate. It sounds barbaric. There's a lot of
they put cages in the heart.
Exactly.
They're called stents.
Yep, exactly. So we basically put this surgically in the prostate, and it's like a cage, and it slowly over the course of a week creates some incisions in the prostate to kind of open things up, and then it has to be removed a week later.
Oh, it creates. They're called otomies. See, we do otomies in all kinds of parts of the body.
Yep.
So it's a urethrotomy device. I'm just figuring this out right now. So you put it in the urethra. And so what do you do while it's in for that week?
Just hope that they're comfortable enough. It can be a little bit irritating to patients while it's in there.
Are you even continent? Well, I mean, can you even
some people
control your pee?
Some people, I think, leave catheters in there. I don't. I personally don't do the procedure myself. I have some partners that do offer it. Some people could leave a catheter, but most people aren't incontinent while it's in there. I think the biggest issue is just it can be a little bit uncomfortable to have that device in the prostate.
Sounds uncomfortable, but then you take it out a week later, and it's made some, I assume, radial incisions there.
Yep.
And that can increase the caliber, the size of the tube. And I'm going to throw some math and some physics at people here. Flow is dependent on the radius of a vessel. 1 over the radius to the 4th power.
That's right.
And what that means in English is that a small increase in the radius can result in an enormous increase in flow.
Exactly.
I mean, is that an accurate
that is
simplification of this?
Hit the nail on the head.
So if you just open the urethra a millimeter, you can dramatically increase flow. Fascinating. That's why they make us learn physics and math.
At the time, it doesn't make sense. To
right.
learn all that
Why
stuff.
am I learning differential equations? It almost killed me. At least I've got the basics in hand. So, the oldest, most common procedure is something called a TURP.
Exactly.
What is a TURP, Phil?
TURP stands for transurethral resection of the prostate. So, in men with these urinary symptoms, we can take a camera, look inside the urinary tract, and we will see in the prostatic urethra, the first part of the urethra that the urine passes through on the way out. As it grows, it kind of pushes in the middle. There's two, what we call lateral lobes of the prostate, and they're kind of smushed in the middle.
All right.
They're reducing the diameter, the radius of that channel. So that with a TURP, we go in with you asleep. We use a little camera, and it has a little loop that has electricity, basically cautery.
Right.
And we use that loop to slowly kind of resect the prostate, shave it out from the inside.
You shave it out, so you're scooping out little chips.
Some people call it the roto-rooter procedure.
It's called the roto-rooter. Very good. So you can go with it while per guy's asleep, but they're not cutting on the outside.
No incisions.
It's a telescope,
mm-hmm.
and then you can use this cutting loop. But how do you know how much to cut, Phil?
You usually when you get towards the kind of lateral edges of the prostate, the capsule we call it, there's some changes visibly that you can see that tell you, hey, I've resected enough.
So you know when to stop.
You know when to stop. And then there's a little bit of bleeding that comes with that. The prostate is heavily vascularized, so there's always
a lot of blood vessels.
A lot of blood vessels. There's always blood when you cut into it. So we'll spend some time to kind of cauterize or fulgurate those blood vessels to get them to stop. And then some people send you home with a catheter in place. Some people will keep you in the hospital for one night just to make sure you're not having any issues with that catheter.
Now, how does a guy remain continent? How come a guy just doesn't leak urine all the time after a TURP?
Yeah, so you have a couple different continence mechanisms that keep you dry, keep you from leaking urine. And there's something called the external urinary sphincter. And that is the sphincter that we have that we control with our mind. So
if I have to pee and I'm contracting, it's the external sphincter.
Exactly.
We have sphincters throughout our body. It's just a circular muscle that contracts things.
Exactly.
So are there two sphincters?
There's an internal urinary sphincter as well near the bladder neck.
So near the bladder.
And that is where your tamsulosin or your Flomax works to relax that.
The
that
internal
area.
sphincter. You still have an external sphincter.
Correct. So even when your bladder's full and your brain says we need to empty, you can still kind of override that with the external sphincter. And as long as that external sphincter is not harmed with a BPH procedure, then continence should be intact.
So an experienced surgeon like you who does this all the time, who's been properly trained with the right equipment, got people understanding you got to be able to see what you're doing.
Got to be able to see.
If you maintain the integrity of the external sphincter, then incontinence is not that big of a problem.
It's very rare.
It's rare. Now, the next thing guys are going to want to know, does it affect sexual function? Does it affect erections? Does it affect fertility? What are the now? Thank goodness when a guy's having a TURP, usually he's older, and if he's going to have kids,
fertility is not a huge
fertility is not much of a concern anymore. Well, so what are the effects of a TURP on fertility and erectile function?
There are definitely some trade-offs. So, erectile dysfunction is not very common after a TURP. It can happen. I'd say somewhere between 5 and 10% of the time you can have some decreased erectile function.
It used to be a lot more common, wasn't it? But you're getting better now?
I think things have gotten a little bit better. I think nowadays there's some, technical things that we can do. We do what's called bipolar TURP. There's a little bit less spread of heat. I think it's heat that causes a lot of those issues. So erectile dysfunction can happen, and then most people are going to have ejaculatory issues.
Exactly.
Exactly.
So does that essentially block the vas?
It basically, with the bladder neck and everything open upstream, a lot of times when there's ejaculation, everything goes up in the bladder.
It's what's called retrograde.
Retrograde ejaculation.
And you just pee it out, and it's no big deal.
So some people, if they're obviously worried about fertility, that's a big deal. But a lot of men are, pretty distressed psychologically by that fact that they could have, orgasm should be unchanged, but there would not be ejaculation.
But there's
it's like a dry fire.
A dry
fire.
Dry fire.
Yep.
Interesting. So a TURP is safe. You can do it as an outpatient. You can stay in the hospital one night. And in the hands of an experienced surgeon like you, complication rates such as incontinence should be low.
Exactly.
Erectile dysfunction should be low. Now, if the prostate's getting really big, are there other things you can do more advanced than a TURP for, and I'm sticking with the benign prostate still, and then we're going to move on to cancer. Is there anything else you can do that's even bigger than a TURP?
There is. So there's really 3, I think, go-to procedures for the guys that have the prostates bigger than 80 grams. Those really big prostates.
The really big ones.
The really big ones. There is a procedure that's been around for probably a decade or so, a little bit more, called a HOLEP, or a holmium laser enucleation of the prostate. Similar to a TURP, it's a telescope in the urethra. And instead of using a cautery loop to shave out the prostate, we use a little laser fiber that we would use for like kidney stones.
Okay.
And we kind of core out the prostate from the capsule, push it in the bladder, break it up into pieces and pull it out. So you can take big pieces of prostate out
with the holmium laser.
Exactly.
That sounds tricky.
It is. It's very technologically involved. So a lot of urologists don't do the procedure. I think it's one of those things that if you trained at a place that did a lot of them, you're ready to go. But it's a very steep learning curve from a surgical perspective.
Do you do it?
I don't.
Okay.
I didn't train.
Leave it to the people that have the training.
Leave it to the people that are good.
You don't need that headache.
That's been a kind of a game changer, I would say. I think overall the symptom improvement is just as good, if not better, than a TURP. There is still some of that ejaculatory, dysfunction that can happen.
Okay.
Erectile dysfunction is pretty rare because the laser doesn't, generate as much heat. So I think that kind of took a lead in BPH management for those guys with big prostates over TURP.
So the nerves that go to the penis for erection go around the prostate. They're in the capsule. They're on the side. So if you can stay inside or medial to that, you should be doing good.
And then there's an even newer one that I think is going to be a pretty big treatment in the future. It's called aqua ablation. And
what is that?
It is. I tell people it's like a pressurized water jet. So videos where a water jet cuts a wrench or some piece of metal. In half, super high pressure water jet. It's a robotically driven, ultrasound guided machine that we map out where we want to treat the prostate, and it uses pressurized water to basically just obliterate the prostate tissue.
Oh my goodness.
Yeah.
So you'd have almost no heat, but you got to aim it properly.
Exactly. So you'll go in usually afterwards and stop a little bit of those bleeding blood vessels. So there's a little bit of heat, but the best thing, I think the biggest selling point for aquablation is that we're able to spare the bladder neck. We're able to spare the verumontanum, which is a structure in the prostate where a lot of the ejaculation comes from.
Okay.
So you can spare those. So most men have preserved ejaculation. Erectile dysfunction is about 0.5%. And they have just as good as improvement in urinary symptoms as they would with TURP and with HOLEP.
What guides the water jets? Is this like some computer program?
It's a computer program. So
really?
It's kind of robotically driven. We decide where we want to treat the prostate and how deep we want to treat the prostate with the water jet. And then while we're treating, we're watching it on live ultrasound to see where the treatment's going
so you're kind of guiding us. So you're in the room.
Correct.
The surgeon is there.
Correct.
Fascinating. Now, tell me the name of that one again.
It's called aqua ablation.
Aqua ablation. I didn't know anything about that, so let's keep our eye on that for in the near future. Fantastic.
I think it might be the go-to. I don't know in the future. I think it has some staying power.
Very exciting. So early reports are favorable.
Early reports are great.
Fantastic, Phil. So let's move on to the final topic, prostate cancer. Mm-hmm. Prostate cancer is very, very common.
Very common.
And it's kind of an interesting cancer in that, and please correct me if I'm wrong, that a lot of it, maybe the most of it, is a very slow-growing, low-aggressive type of cancer. Is that right?
Certainly. So there's kind of a spectrum of disease when it comes to prostate cancer, and I think this goes back to PSA screening. Mm-hmm. In the past, when we didn't know as much about prostate cancer and survival and outcomes, if you were diagnosed with cancer, generally they'd say, we need to treat this. We're going to do radiation. We're going to do surgery to remove the prostate.
Or powerful
hormones. And that comes with a lot of side effects. Mm. But if it's life-threatening, then it's generally worth those side effects.
Right.
And I think there's a lot of men who received treatment in the past for those low-risk diseases that probably weren't going to shorten their lifespan. And that has costs associated with it, decreased quality of life. Mm. So those screening recommendations that are based on those guys that had treatment when maybe they didn't benefit, kind of obscures the picture a little bit. So as time has gone on, we've gotten better at determining, do you actually need to have this treated? Because if it's not going to shorten your life.
Because if you're 80 years old,
exactly,
90 years old, something's going to take you out. Your heart, a stroke, or something else. And if you have a little bit of prostate cancer, it's hanging out.
Most people die with prostate
cancer.
They
die with it. Mm-hmm. Is that called watchful waiting?
Watchful waiting. Active surveillance is another name.
Active surveillance.
Exactly.
So that is perfectly acceptable. Now, how do you know if it's a low-grade cancer?
We will do a biopsy. Biopsy is really the only way to know if there's cancer. So that's a procedure that we do in clinic. No anesthesia. Most patients tolerate it great. We basically use a little needle to take some samples of the prostate and send them off to a pathologist, and they look at it and assign it what we call a Gleason score. That is basically just a scoring system that they use to.
We recently had an anatomical pathology podcast with one of our local. Dr. Taylor, in fact, Alex Taylor, and he was telling us a little bit about this, but tell us more. So you get a biopsy, you get a sample. Then we send it to a pathologist, and he happens to be subspecially trained in
GU pathology.
GU pathology. So he can look at this tissue, tell you what kind of cancer it is, and give you some idea how aggressive it is.
Exactly. They look at how typical versus atypical the cells look under the microscope. So cancers tend to be a lot of cancers grow fast, but they don't necessarily do a good job of, making normal structures. They look very atypical under the microscope. So the more odd or atypical something looks, generally the more aggressive it is. So they look at all these slides under a microscope, they assign it a score. It gives us what's called the Gleason score, and anything 6 to 10, 10's the highest it can be. Anything 6 to 10 is considered prostate cancer.
Prostate, okay. So let's say a guy's got a prostate cancer. And is younger, let's say, is a good surgical candidate, otherwise healthy guy. What are the usual treatments now? I assume there's you tell me, please.
Yes.
What are the treatments?
I think the go-to, the recommendations still are either surgery versus radiation. Surgery to physically remove the prostate, take it out of the body, and then we have to attach the bladder back to the urethra. That is one option, and then radiation to the prostate. So external radiation.
So it's a beam.
It's a beam to kill those cancer cells.
So that can be done. Now, I believe they hit the beam, they hit this way, this way, this way. So the concentration is on the target, but the tissues around it are still getting some exposure.
They can, yep.
So you've got rectum, you have urethra, you have bladder, you have other things down there that get some collateral damage, right?
Exactly, some scatter radiation.
Now, what are these seeds? What are these radioactive seeds I've heard about?
Yeah, so that's called brachytherapy. These are basically like small little implants that emit radiation themselves. So they're placed through the skin into the prostate, and they slowly emit radiation over time to the tissues nearby, and the goal is to, again, kill those cancer cells.
Do you still do that?
It's done, but it's not done, I'd say, as common. I think external beam radiation is a little bit more common nowadays.
Because I would think you're leaving these seeds, and they're like the size of a grain of rice,
exactly,
right?
Yeah, they can cause some problems, as radiation and surgery can as well. But I think it's shifted a little bit more towards external beam radiation therapy.
Gotcha. Now, if you need surgery to take out the prostate, there's been a huge revolution in technology to do this.
There has been.
Tell me about it.
So in the past, we would do, it was a big surgery to take out the prostate, and it still is. But in the past, we would have to do an incision, a large incision in the abdomen, to take out the prostate and sew everything back together. When the robotic surgery platforms came out a couple decades ago, urology was one of the first specialties to kind of adapt to that model, because we're able to take it out with some small poke holes. We're able to get patients out of the hospital a little bit faster. I think there's decreased rates of leakage of urine.
So you can do a better job with the robot.
Correct.
Because you can reach down in a tight space, and the robot allows you to have wrist movement, so you can get in there and get really good angles.
Yep. It's like your hands are in there, but
it's like your hands are, but you got tiny little hands. There's a political joke in there. I'm going to leave it alone. And you can do even a better job with the robot through small holes.
Exactly. So I think outcomes have improved for patients, and it's one of, we do a lot of robotic surgery ourselves as urologists, that maybe there's not necessarily an improved outcome over laparoscopic surgery or open surgery. But patients tend to get out of the hospital a little bit quicker. But I think in prostate cancer, it actually has improved outcomes.
It actually has. It's not just a bell and a whistle.
Correct.
Right. A lot of the surgeries I still do with what are called sticks. It's a laparoscopy. If somebody needs a robot, I just send them to the robot person. I missed robot by about 20 years in my training. But you, on the other hand, you've trained with the robot.
I did.
It's been a part of your training since the beginning.
It was. So I trained at the University of Oklahoma. It's a pretty robotic-heavy program. We do a lot of robotic surgery, mostly for cancer. So robotic kidney surgery, prostate surgery.
You can even get the robot up to the kidney.
You can. You can. They're even doing chest surgery nowadays. So like lung surgery, they're doing.
Oh, yeah, it's everywhere.
It's everywhere.
Neurosurgery, they put cameras, robots everywhere.
Yep.
So you can do the kidney as well. So I assume you do a fair number of prostatectomies for cancer. Now, you can take that out. I've seen some of these. You take out what are called the seminal vesicles with it, and you can spare those important nerves that guys are going to care about usually. So by being very accurate, staying inside the nerves, you can get the prostate, you can get the cancer. But then you have to put the urethra, because if you're missing a piece of urethra now, you need to put that back together. How does that heal up? That
heals pretty well. So one thing that can happen after you take the prostate out and we kind of sew those two pieces together, you can get some scar tissue that forms. It's called a bladder neck contracture. And with the robot, since we're able to see very well, we can see those mucosal edges, the inside of those structures, and get them together quite nicely. So bladder neck contracture rates are lower. And then urinary incontinence is a little bit less common as well. So leakage, everybody leaks after surgery, but most people over the course of a year tend to gain that function back, and leakage improves.
So the external sphincter is more likely to be preserved. Is that what I'm hearing?
Correct. Exactly.
Okay, but there's still some damage. So after prostatectomy, some leakage is common.
Yeah, you're relying only on that sphincter. So the goal over that year is to strengthen that muscle, since you have control over that muscle, to strengthen that and improve leakage.
Now, if the cancer is confined to the prostate, meaning it has not spread out, are you looking at cures?
We are. So surgery and radiation both are treatments with intent to cure. I tell patients all the time it's kind of a tough decision because neither one has a better cancer outcome. Neither one is better oncologically from a cancer perspective. They're just very different treatment options. So it's not like we're giving people option A and option B. It's option A and option A, and they're just very different. So some people struggle with that decision, because they're very different side effects,
Right. I have a friend, I will not name him, but he's older and he had prostate cancer and he had radiation treatment. And he says urinating felt like he was peeing lava. Peeing lava. Oh, I'll never forget that. Oh my God, pee lava, or have the surgery that can have leakage. But at least they're both curing you potentially of cancer.
Exactly. That's the goal, is to cure.
So what if it has spread already and it's beyond the prostate? What do you do about that?
Yeah, so in that situation, we can't necessarily cure the prostate cancer, but we do have a lot of treatment options. That's probably where the management has changed the most over the last 10 years or so. We know very well that prostate cancer cells rely on testosterone as a kind of a necessary fuel for their growth and spread. So the hallmark of treating those is to basically stop testosterone production.
Is that what Lupron? You still use Lupron and
exactly.
Novaldex?
Yep. So there are these medications that we give that shut down that system. In the past, again, 20, 30 years ago, before these medications were available, what we would do is we would basically just take the testicles out.
In the old days,
In the old days. So you would just take the testicles out, the testosterone would drop, and it basically puts it into a remission. The PSA drops significantly. The problem is eventually all the cancers will overcome that blockade of testosterone, and the PSA will come up, and it'll continue to spread.
So it buys time.
It buys time.
And there's nothing wrong with that. Mm-hmm. If it's spread to lymph nodes, is there chemotherapy for prostate? Are there any advances in antibodies or advanced biologics?
There is. So chemotherapy is an option. Generally, that's for people who have high volume, widely metastatic disease. People that tend to be a little younger and healthier with really bad disease because they're going to tolerate chemotherapy well. So people that come in, those people that maybe they didn't have a PSA checked and they come in with a very high level. It's spread everywhere, the bones, the lymph nodes. Those are the people that up front will probably benefit the most from chemotherapy, paired with that, the Lupron, those medications that drop the testosterone. But chemotherapy is an option. There's some other options for people with disease in the bones. There's something called radium that is basically a radioactive isotope that we administer that is delivered to those spots in the bones. And
how do you deliver radium?
It is basically just tagged to a molecule that goes to
so it targets. So it's a molecular target. You're not going in there and trying to hit every spot.
Correct.
It finds its way.
It finds its way. So one thing that's come up in the last several years is a PET scan. So PET scans are basically like CAT scans that find cancer cells. There is one that's specifically for prostate cancer. It's very highly specific for PSA and prostate cancer cells called PSMA. And that's kind of the go-to test to see if this is spread outside the prostate. And now they've taken that molecule and they've attached radioactive isotopes to it, and then it delivers it to the prostate cancer cells.
Love it.
So that is for the guys, again, that have kind of exhausted all the other therapies. It's a way to kind of attack those prostate cancer cells.
Now, do you work closely with oncologists?
We do, very close, especially in these advanced prostate cancer cases.
So you'll tag team these with a team, a multidisciplinary team is called. So you've got the medical oncologist, you got the radiation oncologist,
genetic counselors,
the genetic counselors.
There's more genetic links that we're finding to prostate cancer. I know everybody hears a lot about breast cancer,
right?
Those BRCA mutations that women can have that predispose them to breast cancer. There's very good evidence that men that have a strong family history of breast cancer can get those BRCA mutations, and they can have highly aggressive prostate cancers. And there's a whole set of medications that we can use to target those people who have those mutations. So, we always ask about family history of prostate cancer, but breast cancer is actually a pretty big risk factor as well.
Interesting. So you can get targeted, individualized, custom, whatever you want to call it, treatments for cancers now. And that's only going to get better.
It's only going to continue to evolve, yeah. Every year it changes.
Amazing. So it's fast-paced.
Very fast-paced.
Wow. So a common theme that I bring up on almost all these podcasts is that it's so important to find an expert like you, an expert team that has experience in this, and people that are staying cutting edge with the latest information, because it's just changing all the time.
It's hard to keep up with.
It really is.
It is.
And that's why you have to specialize. You can't, as an individual, you just cannot keep up with everything. That's why we need to have teams and specialists like you and me.
Yeah.
Fantastic. Well, is there anything else about prostate disease that you would like to tell us about here? Is there anything that I've missed, Phil? Any other exciting treatments on the horizon? Artificial intelligence, biologics.
I'm sure that AI will make its way into prostate cancer at some point. I think the BPH is probably the most important topic, because there's a lot of guys out there that I think suffer in silence. They just don't seek care. They're either embarrassed or they're worried about side effects. I think it's important to talk to your physician about that, whether it's a urologist, whether it's your primary care doctor. A lot of people, it gets so bad that they get to the point where their bladder holds 3 liters and they can't empty no matter what. It can kind of get to that point where the damage has been done. So,
so early like many things in medicine, early treatment's
key.
Is key.
Yep. And a lot of people won't complain like my stream is decreased. It's such a chronic issue that happens over time that they don't perceive that it's changed.
And it's slow.
Exactly. Then you start to get leakage of urine. You go into retention. Can't empty. Have to have a catheter placed.
And that can affect your kidneys too, right?
Can affect the kidneys.
Severe problems. It backs all the way up.
It can. So at that point, sometimes it can get to the point where it's too late. So if you feel like you're having those symptoms, if you feel like you're getting up at night too much, you're starting to leak urine, you think the stream is decreased, it takes a long time to empty, I would talk to your doctor about that, because we have a lot of good treatment options.
Fantastic. Well, Phil, thank you so much for a very informative discussion. I've certainly learned a lot. I hope our listeners have as well. And once again, welcome you to the community. It's wonderful having you here, and it's wonderful to have such great colleagues to share these podcasts with.
I appreciate you having me.
Thank you very much, Phil.